In this presentation, I'm going to talk about liver transplant dietetics from pre-transplant to immediately post-transplant, recovery and long-term care and health. And this information is up to date in May 2021 and is relevant to Cambridge University Hospitals NHS. This chart is showing the indication for liver transplant from 2019 to 2020. So you can see that the leading indication for liver transplant is alcohol-related liver disease, followed by liver cancer, and then PSC and PBC, metabolic disorders, other causes of liver disease, autoimmune and cryptogenic liver disease, regrafts where previous liver transplant grafts have failed, hepatitis B and C, and acute liver failure. So you can see that the types of patients having liver transplants are likely to be quite varied based on these liver disease diagnoses. Patients are selected for a liver transplant based on their risk of death without having a liver transplant. So to be considered for an elective transplant, they have to have an anticipated length of life without a transplant that's less than that would be obtained with a transplant. Additionally, all patients selected must have a projected 5-year survival after transplant of greater than 50%. And after these two criteria, selections assessed secondary on the ability of the transplant to improve quality of life. For example, for people with polycystic liver disease who might not have a life-threatening liver disease but very poor quality of life. All patients who are considered for a transplant are assessed by the multidisciplinary team, and this includes people like the surgeon, anaesthetist, hepatologist, transplant coordinator, psychology specialist nurse for people who have alcohol-related liver disease, and the dietitian also does a nutritional assessment. I won't go into detail with this now because if you'd like to know more, then you can check out the nutritional assessment presentation. But in summary, we look at their anthropometry, including upper arm and grip strength and weight history. We'll soon be assessing frailty status, nutritional intake and barriers, nutritional losses, bowel function, diabetes control. We look at blood tests, including vitamin and mineral levels and celiac screen, and then we provide education and support and arrange for dietetic follow-up. The dietetic care of patients waiting for liver transplant is the same as hepatology patients. So, for example, providing support with cirrhotic eating pattern, high protein intake, and nutritional management of symptoms such as ascites. And the aim for people who are waiting for a liver transplant is, if possible, to optimise their nutritional status, or if that's not possible, just to support them with minimising losses in nutritional status. Because people have end-stage liver disease, sometimes it's not possible to stop the decline in their nutritional status, but to try and minimise it. And we would be aiming to optimise nutritional intake and diabetes control while people are waiting for their transplant. Now, some people will be considered not eligible for a transplant because their risk is too high at their transplant assessment. So, for example, some people may be too obese for a transplant, or they may be too malnourished or too frail. So for these people, they may not be listed, but they might continue to have dietetic input with the aim to improve their nutritional status and frailty status so that the risk of transplant is no longer too great, and they become eligible for transplant. And the criteria for this is different for every individual patient, so there's no cut off for high BMI and people not being eligible. It depends on other factors such as how frail they are, their cardiovascular risk, their anaesthetic risk, their challenges with surgery and their surgical risk. So it's the overall assessment together, and an individualised aim would be set for patients. In the first days after a liver transplant, we would be providing nutrition support, and the nutrition support that is needed will depend on the individual patient. So there's two different types of biliary reconstruction with a liver transplant that's relevant to dietetic care. So one type is a duct-to-duct biliary reconstruction, where the bile duct of the donated liver is joined with the bile duct of the patient, the recipient. And this type of surgery is obviously the same anatomy then as somebody who hadn't had a transplant. But this is only possible to do if the bile ducts are similar enough in size and if the recipient's bile duct isn't diseased. So for example, people with PSC and PBC might have diseased bile ducts. It's not possible to join them in this way. So if it wasn't possible to do a duct-to-duct anastomosis, a Roux-en-Y anastomosis would be undertaken, and this is where the small bowel is dissected at the jejunum and brought up to the small bowel as it leaves the stomach, and the bile duct is joined to the small bowel there, and the two pieces of small bowel are joined side to side down here, up here, and side to side down here. So you end up with a Roux-en-Y anastomosis. And this is relevant because patients who have a duct-to-duct anastomosis have not had their bowel dissected, whereas obviously with a Roux-en-Y they have. And so dietary intake and bowel movements can be slower in people with a Roux-en-Y. Traditionally, they used to keep people nil by mouth for 2 days with a duct-to-duct and 5 days with a Roux-en-Y, but more recently they are trying to tailor this to the individual and their tolerance rather than having set days. And sometimes people start with oral intake on day 1 post-transplant now. So the patient's journey within the hospital is, after their liver transplant, they are admitted to the ICU and they'll still be sedated and ventilated at this point. And if everything has gone smoothly, which is often the case with liver transplants, they extubate them and lift this sedation on the day that they have the transplant or the day after the transplant. And then as soon as possible, normally within a day or two, patients are transferred to the high dependency transplant unit, and they normally stay there for a day or two, depending on how complicated their care is and how well or unwell they are. And then they are transferred to the transplant ward for the rest of their hospital stay, unless they get complications and have to go back to surgery or back to high dependency or intensive care unit. And they normally stay on the transplant ward for 2 to 3 weeks. So their length of stay in total is normally 2 to 3 weeks. And then they are discharged home at that point. And how long they stay depends on what complications they experience. So some people can get bile leaks and have to go back to surgery. Some people can get rejection of the liver or infections and have to stay longer to treat those things. But all going well, length of stay is normally a couple of weeks. So in terms of progressing nutrition support, when patients come out of their operation, they have a large bore NG tube in situ, and this is normally just used for drainage. And if the output is not high, it will be spigoted, and how well patients tolerate this will be assessed based on whether they're experiencing nausea and vomiting once they're awake. They often move on to sips of fluid on day 1 post-transplant, and then when tolerating this, free fluids, which can also be day 1 post-transplant. And then normally the first or second day post-transplant, they're recommended to have a light diet, and this means diet to tolerance really. So often people will start with soft moist things because that's what they fancy. and then they move on to a normal diet once they're tolerating a small amount of dietary intake. And in terms of nutrition support, what we provide is tailored to the individual patient. So if a patient is malnourished, we will be recommending tube feeding. So normally NG feeding is tolerated, but if not, then NJ feeding until they're able to establish oral intake. And we'll start nutritional supplement drinks early, so that we can start weaning feeding and move on to oral intake, and then encourage them to be having little and often high energy intake whilst they're on the ward. And normally patients would continue with oral nutritional supplements for the whole time they're in hospital, and often take home a week or two's supply if they don't already have them at home from pre-transplant. After a liver transplant, patients are provided with food safety advice, and we recommend that patients avoid grapefruit, pomelo, which is an Asian grapefruit, pomegranate and Seville oranges, which are used to make marmalade, for life. And this is because these foods interact with their medication. The research that has been done shows that for some people, these foods make their medication more effective and can raise the levels of their medication in their blood, so they can give them side effects of the medication. And for other people, it can make the medication less effective or reduce the amount of medication in their blood and increase the risk of rejecting the liver. We also recommend good food hygiene for life. So there's an increased risk of getting foodborne infections after a liver transplant. So we recommend that people follow good food hygiene practices, and I'll talk about this more in a minute. We also recommend avoiding foods that are higher risk of causing foodborne infections, usually for around the first 6 months post-transplant, and in the future if they're being treated for rejection with high doses of immune suppression. So this is recommended because when patients are on high doses of immune suppression, their immune system is the most suppressed, and so the risk of getting food poisoning is the highest at that point. Over the first 6 months after a transplant, their medication is normally reduced until they get to what's called a maintenance dose of medication, where they'll be on the lowest dose of medication to reduce their risk of rejecting the liver. But sometimes people can experience episodes of rejection where their immune suppression medication is increased again, and so then the risk of food poisoning would be higher in those times. They'd need to be more careful with avoiding the foods that increase this risk. And I'll talk a bit more about the details of what foods need to be avoided a bit later. We recommend that people cook pork and shellfish thoroughly for life, and this is because there's a risk of getting hepatitis E with these foods. And if a patient who's had a liver transplant gets hepatitis E, there is a risk of death and organ failure. Now, different transplant centres provide slightly different advice, and because of social media, patients from different transplant centres are more connected now, and so there is some discussion amongst patients about the different advice that they get from different transplant centres. So the advice that I'm telling you about today is what we currently advise in May 2021 at Addenbrooke's Hospital in Cambridge. We give patients written information about the foods that they need to avoid after a transplant, and we do this before they leave the hospital, normally when they're starting to eat food that's brought in by visitors or that they're going down to the hospital shops to buy, and when patients are ready to receive this information. So we recommend that unpasteurised milk, yoghurt and cheese is avoided, and soft mould ripened cheeses and soft sheep's and goat's cheese is also avoided. Eggs that don't have the lion stamp on them need to be cooked all the way through, but if the eggs are lion stamped, they can be undercooked. And we recommend that fish and shellfish are thoroughly cooked, and that patients only have smoked salmon if it's eaten straight away from a freshly opened packet. Meat needs to be thoroughly cooked, so no rare steaks or undercooked meat. And smoked meat such as salami, pepperoni, those sorts of meats, they also need to be cooked if they're going to be eaten, so they can't be eaten just smoked or cured. All deli counter meat that's already cooked, such as ham sliced from the bone, needs to be cooked again, otherwise that needs to be avoided. And rotisserie chicken needs to be avoided. Pasteurised pate is allowed, but any unpasteurised meat or vegetable pate needs to be avoided. And fruit and vegetables need to be washed thoroughly before they're eaten. And any salads from an open counter that can't be washed, such as coleslaws, potato salads and olives, need to be avoided. They need to be bought from a sealed packet from the fridge instead. And then any ice cream or iced drinks or milkshakes from a soft ice cream machine, milkshake style machine, need to be avoided. So things like 99ers, Mr. Whippy and McFlurries and Slush Puppies, and milkshakes from Burger King and McDonald's. We also recommend good food hygiene advice, so not using foods past the use by date, storing foods properly and putting them straight in the fridge and freezer once they get home, washing hands before preparing food and covering up any cuts and wounds before handling food, making sure that utensils and chopping boards are cleaned before use, and that different chopping boards are used for cooked compared to raw foods to avoid cross-contamination, that meat is defrosted in the fridge rather than at room temperature, and that when reheating food, ensuring that it's piping hot all the way through, paying particular attention to food that's reheated in the microwave because there can be hot and cold spots. So making sure that cooking instruction and reheating instructions are followed and that the food is piping hot all the way through, not just in places. We recommend that food is only reheated once because the more food is reheated, the increased risk of getting food poisoning from it. And that if possible, patients check their fridge and freezer at the correct temperatures, so 5 degrees for the fridge and less than -18 for the freezer. And that once food is defrosted, it's not refrozen unless it's cooked in between. So if, for example, some raw mince is defrosted and then cooked, it can be refrozen in the cooked form and defrosted once to be eaten. That food in the fridge is covered up and that raw stuff is stored at the bottom of the fridge rather than at the top so that it doesn't drip into cooked food. Patients can eat out and they can have takeaways, but they need to ensure that there's good food hygiene. So we recommend that people choose food hygiene ratings of 4 and 5 when they're looking for their food outlets, and this can be found on the Food Standard Agency website. We recommend that people avoid buffets and carveries if possible, particularly for the first 6 months after a transplant. And if this isn't possible, then they should be one of the first people up to eat and select their food before the food has been sat around for a long time and before multiple people have had contact with the food. We recommend that with barbecues, making sure the food is cooked all the way through and it's not left sitting around for long periods, and that different tongs are used to take the cooked meat off compared to what's used to put the raw meat on, so there's no cross-contamination. And if eating out abroad, that extra care is taken because food hygiene might not be as good as in the UK. Thinking about recovery post-transplant, we would provide nutrition support until a patient's appetite and intake had improved. So it often takes a couple of weeks until they're eating well, maybe longer. And a lot of patients are sarcopenic and malnourished after their transplant from their pre-transplant illness and from not eating as well after the operation and ongoing muscle loss. And so we'd want to treat their malnutrition and their sarcopenia. So we're providing nutrition support until they achieve a healthy BMI and trying to promote muscle and strength regain as well. So good quality nutritional intake and physical activity at the same time, which can be challenging after large abdominal surgery. We would then wean the oral nutritional supplements and transition to healthy eating once their intake had improved and once their malnutrition was resolving. And we also need to take care that patients don't regain too much weight. So after a transplant, once they're feeling better, their appetite's improved, their liver function is good, so they're now storing nutrition, they're not needing a cirrhotic eating pattern from about a month post-transplant once the liver's working. And a lot of patients report an excessive appetite, feeling so hungry that they can't be satisfied from food, and so they eat a lot. And this might be as a result of the steroids that they're on for the short-term post-transplant, and it might be their body trying to replete their nutritional stores after being malnourished and unwell for so long. It might just be that people are feeling hungry again and enjoying food again, but there's obesity and weight gain, excess weight gain is common after a transplant, and physical activity levels are low for quite a long time after a transplant. So patients are told to be careful not to damage the surgical site, so being careful with their physical activity for the first 3 to 6 months post-transplant. And they're also still not feeling particularly well, not feeling, still getting fatigued, not feeling that full of energy, so they're eating much more but they're not moving around very much, and so that's why weight gain and too much weight gain can be common. So it's getting that balance between treating malnutrition, transitioning to then a healthy diet at the right time, and helping people to move away from that eating 6 times a day, high calorie eating pattern that they needed before the transplant because of their liver disease, and then preventing too much weight gain as they recover after their transplant. The PENG and ESPEN guidelines give recommendations for estimating requirements after liver transplant, and we'd slowly increase nutrition to meet requirements over the first 48 hours because patients are in a catabolic state after their surgery, and once they get into the recovery phase, then we would be adding additional calories for repletion if needed at this stage. It's important to note that energy requirements are not elevated in the long-term post-transplant, and there is a risk of gaining too much weight and overweight and obesity. So increased requirements are only needed for repletion in the short term and for short-term recovery post-transplant. Patients can experience complications after a liver transplant that require nutritional intervention or influence nutritional intake. Hypoglycemia is common, and new onset diabetes after transplant is also common, and this is because of the medication that is given to prevent the organ from being rejected. So in the short term, most patients are on steroids, and these are weaned off for people who don't have autoimmune liver diseases and who also don't have a kidney transplant at the same time. So some patients may stay on steroids long term, and this obviously makes them more insulin resistant, but there are other medications like the cyclosporin and tacrolimus reduces the amount of insulin that the pancreas produces, so they have reduced insulin production as well. So in the short term, we may be needing to provide some advice about diet to help control blood sugars, but whilst also providing good nutrition support. Patients sometimes can experience episodes of rejection, and if this happens, they'll be on intravenous high-dose steroids, and these patients almost always get high blood sugars and a steroid pattern of high blood sugars, where blood sugars are normal in the morning and gradually increase throughout the day, peaking in the evening. Another complication can be high potassium, and this is because the kidneys can be affected by the medication if the dose is too high, and then their removal of potassium from the blood is reduced, and so some patients may need short-term low potassium dietary intake, but the medication would be adjusted to help their kidneys to function better. So they would either reduce the dose of the immune suppression or changed over to a different type of immune suppression that doesn't affect the kidneys as much, and then normally the potassium levels would return to normal, and dietary potassium wouldn't need to be restricted in the long term. Some patients can experience a chyle leak where the lymphatic system is damaged during the surgery, and for these patients we would support them with a low-fat diet to help heal that damage. This would normally only be short-term, between 1 and 3 weeks, and we would be providing nutrition support with carbohydrate and protein to make sure that the calories from reducing the fat was replaced. Some people can experience altered bowel habits, so frequently it takes a number of days for people to open their bowels post-transplant, and then when their bowels do open they can experience frequent loose stools, and this is often because of medications such as antibiotics. In the long term, patients can experience ongoing altered bowel habits and may need investigation into what's causing this, so sometimes certain medications can contribute to this, and immune suppression might be switched on to a slightly different medication to try and help with this. Some people experience small intestinal bacterial overgrowth, particularly people who've had a Roux-en-Y anastomosis. So further investigation is sometimes needed as to why the bowel habits have changed in the long run, and it's often loose, frequent stools that are experienced, and sometimes with urgency. And then also people can experience infections. So because their immune system is suppressed, there's an increased risk of getting infections. And if they do experience this, often their appetite is reduced. Sometimes infections such as CMV can also cause diarrhea. In the long term after a liver transplant, there are some nutritional considerations. Obesity and weight gain is common after a transplant, and so is dyslipidemia, diabetes, hypertension, and these things put together increase the risk of cardiovascular disease and cardiovascular events. So dietetic intervention is often needed, and the dyslipidemia, diabetes and hypertension are contributed to by the immune suppression medication. So it's often the medication that's driving it, and quite often antihypertensives, medication for glucose control and statins are needed, but dietary intervention is also an important part of that management, as well as weight control. And patients are at risk of osteoporosis post-transplant because they've had liver disease and because of the medication that they're taking and their reduced physical activity. So it's really important to make sure that people are meeting vitamin D and calcium requirements and protein, and that they are being as physically active with weight-bearing exercise as they can be. Malignancy is common after a liver transplant, and this is because the immune suppression medication that they're on reduces the surveillance of their immune system to identify cell changes and destroy cells that are starting to change, and so then cancer can develop because that surveillance system of the immune system is suppressed. So trying to achieve a healthy diet that meets recommendations for cancer prevention is really helpful, making sure that fibre intake, fruit and vegetable intake is good, and following the advice for reducing the risk of cancer. And then in the long run, patients do experience liver disease recurrence. So it's important to know that people, although healthy eating is recommended to treat these other conditions and prevent these other conditions, people don't always get better and stay better after a transplant, and they can still be at risk of malnutrition and being unwell from liver disease recurrence, having graft failure where they've had rejection, or for some reason they need a second transplant. Also, people do experience complications like hernias. People with liver disease are at increased risk of things like ulcerative colitis and can need treatment for those other comorbidities. And so sometimes people are not well and nutrition support is needed post-transplant as well. We provide patients with these two information sheets. The first one is nutritional information after a transplant, which provides information about nutrition support for recovery, and then food safety and food hygiene advice. And then once patients are into their recovery journey and starting to think about healthy diet and physical activity, we provide this information sheet about diet and physical activity long term after a transplant. And we have other information sheets, so high blood sugars after a transplant, chyle leaks, high potassium, that we will use if patients require that additional information. And we encourage patients to come back to us if they have any questions or queries after their transplant, even if it's years into the future. So do contact us if you do have any queries about dietetic care after a transplant. In terms of follow-up, patients are referred to Cambridge from all over, from as far as the Isle of Wight, Southampton, Nottingham, Milton Keynes, sometimes Oxford. So we will follow people up if they are staying local to us. If they are not staying local and coming back to Addenbrooke's Hospital, we will follow them up over the phone until they have recovered after their transplant, and then we provide them with the healthy lifestyle information and discharge them and ask them to come back to us if they would like more support in the future. There are two hospitals, Nottingham and Southampton, who have their own dietetic support, because patients tend to go back to those hospitals if they live locally to there, and then they're not followed up again in Cambridge. So we would hand over to the dietitians there after the patient has been discharged from hospital following their liver transplant. So if you'd like some further information, I've put the references of 3 review papers here, and there's also a course developed by the University of Birmingham, hosted by the Future Learn platform, about liver transplantation, which is a free course if you complete it in a short period of time. The Slide website has an introduction to liver transplant presentation, which isn't specifically about nutrition, but it gives more information about the liver transplant process and the selection and care of patients, and has some patient case studies.